Welcome to Vitals and Veins, where we break down the real work behind patient care, built for medical assistants, phlebotomists, and EKG technicians, from students working toward certification to seasoned pros keeping their credentials current. This podcast is for those committed to doing the job well at every stage of their career. Let's get into it. I'm your host, Nichelle. Today's episode is going to be a little different. Instead of starting with clinical guidelines or best practices, I want to start with a real experience, a sharps exposure that I experienced early in my career. So, the purpose of sharing this story is not to criticize individuals or assign blame. It's to examine what happens when systems are unclear and how that affects the people working within them. Because in healthcare, exposure events are not just clinical incidents, they're system events. Before I get into the experience itself, I want to take a moment to get some context. If you work in healthcare, you already know that exposure risk is a part of the job. We're trained on it, we're aware of it, we take precautions to minimize it. But what we don't always talk about is what happens when that risk becomes real, when it's no longer theoretical, and you're the one involved. And more importantly, what happens after? Because most training focuses on what should happen. But in real clinical environments, especially busy ones, that process doesn't always unfold the way it's described. Occupational exposures to bloodborne pathogens are a recognized risk across healthcare settings. When you're performing venipuncture, assisting with procedures, handling specimens, or working in a laboratory environment, the use of sharps is routine. And any time sharps are involved, there is a risk, however small, of injury. Because of this, workplace safety standards exist to protect healthcare workers. In the United States, these protections are guided by the Occupational Safety and Health Administration. These standards require employers to provide training, establish exposure control plans, and ensure access to medical evaluation and follow-up when exposure occurs. In addition, the Needle Stick Safety and Prevention Act introduced requirements for safer devices and tracking of sharps-related injuries. So the systems are there, the protocols are there, but having a system in place is not the same as having a system that works in practice. So at the time of my experience, I had been working as a medical assistant for about 6 years. I was not new to clinical work. I was comfortable with procedures. I had experience across different patient populations and settings, which is important to recognize because exposures don't only happen to inexperienced clinicians, they can happen to anyone. So with that in mind, let me take you through my experience. During a patient procedure, tissue biopsies were being collected. To orient the specimens, small pins were placed into the tissue to indicate positioning relative to the biopsy site. While placing one of these pins, the pin passed through the specimen and through the container it was resting in and punctured my finger from underneath. It happened so quickly. There wasn't time to anticipate it. It was just immediate recognition that I had been stuck. I removed my glove and examined the site. The puncture had broken the skin and I was bleeding. I washed the area immediately, and at that point, there was a decision to be made. Do I step away immediately, or do I stay and finish assisting with this patient? The procedure was nearly complete, and the patient still required assistance. So I remained in the room briefly to assist and ensure that the patient was stable. And this is something that happens often in clinical settings. Patient care responsibilities don't just stop in the moment. I want to pause here for just a moment because there's a part of this experience that's difficult to capture in a step-by-step description. And that's what the moment actually feels like when it happens. Not in a dramatic way, not in any way that's overwhelming, but it's very specific, very clinical kind of awareness. It's the immediate recognition that something has changed, that what you were doing just a second ago as part of your routine is now something that requires attention. And at the same time, everything else is still happening around you. The patient is still there, the procedure is still in progress, and your environment has not paused. So you're holding two things at once. You're aware of the exposure, and you're still responsible for patient care in that moment. And that creates a kind of split focus where part of your attention is on what just happened, and part of your attention is still on what needs to happen next. And I think that's something that isn't always acknowledged in training because protocols assume a clean transition. Exposure happens, response begins. But in real clinical environments, there's often overlap. There's a moment where you're still in the workflow, even though something outside of that workflow just occurred. And how that moment is handled can influence everything that follows. Whether you step away immediately, whether you delay, whether you finish what you're doing first. Those decisions are happening in real time and they're influenced not just by training, but by environment, expectations, and experience. So when we talk about exposure response systems, it's important to remember that they don't start in a vacuum. They start in a moment like this. Moments where clinical responsibility and personal risk briefly overlap. And that overlap is where clarity matters the most. I want to take a step back for a moment and broaden the conversation a little. Because when we talk about sharps exposures, it's easy to picture a very specific scenario, usually something like a needle stick during a blood draw or an injection. But in reality, not all sharps exposures look the same. And I think that's important to recognize because the way we picture these events can influence how we respond to them. Sharps exposures can involve a wide range of devices. Some of the more commonly recognized ones include the hollow bore needles, lancets, butterfly needles, and IV catheters. But exposures can also involve scalpels, suture needles, broken glass, specimen pins, and other less commonly discussed instruments. And in my case, it wasn't a traditional needle stick. It was involving a specimen pin, something that might not immediately come to mind when people think about sharps injuries. The circumstances surrounding these exposures can vary as well. Some exposures happen during active patient procedures, specimen handling, the disposal step of a sharps, and cleaning up after a procedure. Others can happen during an unexpected movement from a patient, equipment malfunction, or contact with improperly discarded sharps. So while we often associate exposures with a specific moment, in reality, they can occur at multiple points in the workflow. So another important difference is how visible the risk is. Some situations feel high risk immediately. You recognize the exposure, you know what just happened. Other situations are less obvious. The exposure may not feel significant, it may not be immediately clear what was involved, or it may seem like something minor at first. And the difference in perception can influence how quickly someone responds. And there's also a difference between routine exposures and unexpected exposures. Routine exposures, if that's even the right term, are those that happen during tasks we perform regularly. And sometimes, because those tasks are familiar, they can be a sense of comfort. Unexpected exposures are much different. They often happen outside the exact moment we're focused on, during transitions, during handling, during cleanup. And because they're unexpected, they can be harder to process in real time. And all of this ties into a much larger point. Exposure risk is context dependent. It's not just about the object involved, it's about what the object was exposed to, how the injury occurred, and what the surrounding circumstances were. Which means that two exposures that look very different on the surface may require a similar level of evaluation. So, why does this matter? Because if we only think of sharps exposures in one way, we may not recognize other situations as needing the same level of attention, or we may underestimate the importance of reporting them, and that can lead to delays or uncertainty or incomplete follow up. And I think that's part of what made my experience feel slightly outside of the expected scenario. It didn't fit the typical image of, say, a needle stick, which can subtly influence how the situation is interpreted, both by the person involved and by the system responding to it. So, when we talk about exposure response, it's important to remember that the system needs to be prepared for more than just one type of event. It needs to account for the full range of ways these exposures can occur, because in real clinical environments, they rarely follow a single pattern. Before we continue, let's take a moment to hear from the educational platforms that support Vitals and Veins. You earned your phlebotomy certification. PhlebCE helps you keep it. Continuing education written for phlebotomists by people who understand the work. Quick to access, easy to complete, and built around the realities of the draw room. PhlebCE.com, where your CE gets done. And we're back, breaking down my personal exposure incident. I want to return to the experience itself, because once the immediate moment had passed, the next part of this situation wasn't about the exposure alone, it was about what happened next. After the procedure was finished, I informed my manager and began completing an incident report. And this is the point where the situation shifts. It's no longer just about the injury, it's about the system that responds to it. It was about 3:30 p.m., and I had asked my coworker to cover my next patient as I completed an incident report as directed by my manager. Once I finished it, I asked her what I'd do next. She had me call employee health, but they had closed for the day. At that time, it was about 4. The backup was the nursing supervisor for the hospital. I called and left a message with them as well. No answer. They also left at 4. I needed to see to the rest of my responsibilities, completing specimen preparation, post-procedure cleanup, and assisting with the remaining patients on my schedule for the day. My manager came into the back work area where I was working and spoke with the back office supervisor in front of all of my other coworkers and the doctors present about my Sharps injury, asking about the procedure I was performing and what standard procedural equipment was supposed to be used. I had followed the procedures and used the standard equipment. I finished my own shift and left at 5:30 for home. It was such a stressful and overwhelming final 2 hours that I could barely think. The following day, I received a call at home from the hospital nursing manager. I felt scolded for not having gone to the emergency department for prompt testing immediately after the exposure. I responded that I wasn't sure what to do, and my manager hadn't mentioned that being the next step for me. I was then shortly contacted by employee health, who told me that the necessary labs for my exposure testing had been ordered, and I needed to go and get those completed that day. I did so, and I waited for my results, which were reported to me the following day via telephone call with employee health. In very dramatic fashion, the employee health nurse asked if I was sitting down, which I was at my workstation in the clinic, so yes, I was. She told me that I had tested positive, but the number was obscurely low, and it was recommended that I talk to a provider in infectious disease. It was incredibly stressful, and not only was there stress and uncertainty, there was also a burden placed on me. Employee health told me that this was my result prior to the Sharps exposure, so it was my responsibility to arrange my care. So I had to contact either my primary care or the infectious disease department and sort this out for myself. I now felt like I was in uncharted territory without anyone to help me. I had covered in that clinic several times and was comfortable messaging one of the docs there via Microsoft Teams, asking for a moment of their time to discuss a workplace exposure result. He reviewed my results and said with such a low value it was likely a false positive and I should complete a different test to confirm, which he then ordered for me. A medical assistant in the infectious disease clinic drew the blood sample, and I waited yet another day for that result, which did in fact confirm the initial result as a false positive. The source patient had initially agreed to testing, but did not complete it, which meant follow-up became even more important. Looking back on this experience, the injury itself was not the most important part. It was the lack of clarity that followed. Uncertainty about the next steps, uncertainty about evaluation, uncertainty about communication. Exposure response should feel structured. It should feel procedural. It should not depend on who happens to be available or what time of day it occurred. So that was the experience as it actually unfolded. And when you step back and look at it, what stands out isn't just the exposure itself, it's the lack of clarity in what came next. So I want to take a moment here and briefly walk through what that response should look like in an ideal situation. Under standards from the Occupational Safety and Health Administration, exposure evaluation should be prompt and clearly accessible. But for that to happen, the system needs to be understood, not just documented. In an ideal situation, the exposure would have triggered an immediate, clear response. I would have been directed to stop working and seek evaluation. There would have been a defined after-hours protocol, and there would have been no uncertainty about where to go. The key point here is this: these are not complex fixes, they are clarity fixes. If you're listening to this and you work in healthcare, if you've experienced an exposure, report it immediately and ensure you receive evaluation. And if you're in a leadership role, your response in that moment matters more than you might realize, because that moment shapes whether people report exposures in the future. In this next segment, I want to spend a little more time on why exposure protocols break down in real practice. Because this experience wasn't just about a single moment or a single misstep, it reflects something broader that happens in healthcare environments. Exposure protocols exist. They're written, they're taught, and they're part of orientation. And yet, when an actual exposure happens, there can still be confusion. So the question is, why do these systems break down in real practice? Because it's usually not due to a lack of knowledge alone. It's often a combination of factors that come together in the moment. The first factor is workflow pressure. Healthcare environments are busy, schedules are full, patients are waiting, procedures are ongoing. And when an exposure happens in the middle of that environment, it doesn't pause anything else. There's still a patient in the room, there's still tasks that need to be completed, and there's still expectations to keep things going. The clock keeps ticking. So instead of immediately stepping away, what often happens is the clinician tries to finish what they're doing first, and that small delay can change how the entire situation unfolds. The second factor is unclear ownership of the process. When an exposure occurs, who is responsible for directing the next steps? Is it the supervisor? Is it employee health? Is it the injured employee themselves? If that responsibility isn't clearly defined, people hesitate. And when people hesitate, the process slows down. Another major factor is after-hours gaps in the systems. Many clinical support services like employee health operate during standard business hours, but healthcare does not stop at 4 p.m. So when exposures happen later in the day, there can be a disconnect between what the protocol says and what's actually accessible in that moment. And if that gap isn't clearly addressed in advance, the responsibility shifts back to the individual clinician to figure it out. Another issue is that many systems rely heavily on memory rather than process. Staff are told during training what to do, but those instructions may not be reinforced regularly. So, when an exposure happens months or years later, people are trying to remember, okay, who do I call? Where do I go? What's the next step? And in a stressful situation, recall is not always reliable. And finally, there's workplace culture. If the culture emphasizes productivity over process, if reporting feels like a disruption, if responses from leadership feel uncertain or reactive, then people are more likely to delay, minimize, or even second guess what to do, even when they know the right steps. So, when we look at situations like this one that I experienced, it's not just about asking what went wrong. It's about asking what conditions made it possible for this to happen. Because improving exposure response isn't just about writing better policies, it's about designing systems that work under real world conditions. Like, take for example, the procedure that I was assisting with was a tissue biopsy collection. And when I had first started, the process had been a plastic container filled with a firm wax. And then the tissue sample was positioned on top of that. And then push pins were placed at different specific points within the tissue directly into the wax dish. And then it was just capped and then sent off to the lab for processing. And these different push pins were color coded and documented about it being 12 o'clock or 6 o'clock, etc. So that was the initial process. And then through likely a sharps related injury, we were reported from the lab that our process needed to change. We could no longer send those tissue biopsy pieces over with pins in them anymore, which seems reasonable, right? They're active sharps just hanging out for somebody else to potentially be injured by. So our process changed ever so slightly because people that had been doing it for a long time in this one particular fashion didn't really want to disrupt our flow. They only changed how we send it over to the lab. We continued using those push pins, but the wax dishes were no longer available because we couldn't send the tissue pieces over to the lab using that container anymore. So we had a plastic tray and the push pins with the tissue, and then we would push them into the tissue. And then after the procedure, we would use suture and needle to tie suture knots in the particular positions and indicate which location was then 12 o'clock or 5 o'clock in the labeling system that was then attached to the specimen in a formalin container. We may have changed the final steps of the process, but we didn't make it any safer during the collection method. And that's where it really broke down. So that's where the pin was able to puncture through a thin piece of plastic instead of having that thick piece of wax barrier to secure the tissue with the pin in. So we can see here how this became a problem. And part of the reason why this had never been problem solved into a better solution earlier on was that there was concern that suturing those knots during the procedure would take more time. And then the provider and the patient would be waiting on that medical assistant who was sitting there tying suture knots into these tissue samples during the middle of a procedure, making people wait on them. So it was all about being expedient more than it was about being safe, honestly. So that is some more context as to what happened here. So likely there was a sharps related injury in the lab. And so they created a solution that we could no longer send over sharps in specimen containers for them to handle. But we didn't get rid of the sharps in the front end of the specimen handling process. And that led to yet another sharps related injury. And I'm no longer at that clinic. So I don't know to this day if anything really changed because there was so much resistance to changing the procedure even after there had been an injury. I think myself and maybe one other employee actually adopted tying those suture knots in the middle of the procedure and practicing so that we could get faster at them and not delay the procedure But there were 6 of us on staff at that time, and I know not everybody was doing it. Not everybody adopted the new procedures because there was a strong resistance in the leadership to go against or make a new process that might potentially inconvenience those who have been doing something a certain way for a long time. There's one more layer to this that I think is really important to talk about. And that's how situations like this don't just affect healthcare workers, they also affect our patients. Because when we talk about exposure events, we tend to focus on the clinician experience, the injury, the reporting process, and the follow up. But every step in that process is connected to patient care in some way. And when systems aren't functioning clearly, that impact doesn't stop with the clinician. One of the first ways this shows up is through delays. If there's uncertainty about what to do after an exposure, if the clinician isn't immediately directed to the next step, if time is spent trying to figure out the process, that's time that's being taken away from patient care. And in busy clinical environments, even small delays can ripple outward. Patients might be waiting longer, schedules may shift, other staff may need to step in unexpectedly. And while those adjustments may seem minor in the moment, they are still part of patient experience. Another impact is repeat procedures. When specimen integrity is compromised, or when there's uncertainty about what happened during a procedure, patients may need to be redrawn. For the patient, that means another needle stick, another appointment, another interruption in their day. Especially for patients who already feel anxious about procedures, that can be pretty significant. And it's something that can often be traced back to breakdowns in the process, not just individual error. There's also the question of trust. Patients trust that healthcare systems are organized, consistent, and reliable. They trust that procedures are being performed safely, and they trust that results are accurate. And when systems feel unclear, even behind the scenes, that can affect the overall perception of care. Even if the patient never knows the details of what happened, the effects of system breakdowns can still show up in their experience. Another piece that isn't always talked about is clinician focus. After an exposure, even if it seems minor, part of your attention is no longer fully on your work. There's a level of awareness in the background. You're thinking about what happened, what you need to do next, whether you handled it correctly. And that kind of split attention, even temporarily, can affect performance. Not dramatically, not in a way that's obvious, but it's enough to matter. And ultimately, this all comes back to system reliability. When systems are clear and consistent, clinicians know what to do, responses are immediate, patient care continues smoothly. When systems are unclear, there's hesitation, there's uncertainty, there's disruption. And those differences don't just affect workflow, they affect outcomes. So when we talk about improving exposure response, it's not just about protecting healthcare workers, although that is critically important. It's about maintaining the integrity of patient care, because the two are directly connected. A system that supports clinicians effectively is also a system that supports patients. So when we look at experiences like this, it's not just about what happened in a single moment. It's about how systems function under real conditions and how that function impacts everyone involved. There are a few key takeaways from this experience. Protocols must be clear and reinforced. Leadership tone matters. Communication reduces uncertainty. And most importantly, exposure response should never feel improvised. In the next episode of Vitals and Veins, my co-host Kirsten and I will walk through what a gold standard exposure response system should actually look like in clinical practice. We'll break down the step-by-step process that should occur after a sharps injury, from the immediate response to medical evaluation, documentation, and follow-up communication. Thanks for listening to Vitals and Veins, the podcast where we explore the real-world practice of healthcare, from specimen collection to clinical safety. Until next time, take care of your patients, take care of your team, and never underestimate the importance of good clinical practice.